Dr. Richardson, you and I were just chatting about why this is such an uncomfortable topic, and why do you think people don't like eyes?
Well, I have to say, I love eyes, and my first degree or my first career before medicine was being an optometrist, which I practiced for 5 years. So I'm fine with it, but I know a lot of people have the ick factor with eyeballs.
Fantastic. Well, hopefully we can overcome that today. So I'm happy to dive in. We're going to start with our disclosures. Dr. Richardson, why don't you go first?
As you can see, it's a fair degree of paucity on this. I have no conflicts.
And I listed everything that I ever got a check from in the last couple of years. So I'll read this out as I've been instructed to. My relationships with financial sponsors include CFPC, the Review Course in Family Medicine, Vital FM Update, Fraser Health, Seymour Clinic, UBC, Doctors of BC, and I do speaker training and professional development lectures. I do not have any patents for drugs or devices, and I'm just starting to be invited on some guideline writing committees, which is a lot of fun. Now, this program has received financial support from the CFPC in the form of speaker honoraria and nothing else. So we've received logistical support, but we have not received any payment from organizations that we're going to mention, and we don't benefit from the sale of any products like the cotton swabs that I'm going to be discussing shortly. So to mitigate bias, the CFPC reviewed and approved session learning objectives, and they set the guidelines for the session. They've reviewed our disclosure slides. The material is peer-reviewed, and the recommendations are based on evidence. Dr. Richardson, editing the ad for our bias?
No bias from me.
Fantastic. So
and no
why do you
either?
Sounds good. Why don't you take us through the objectives, and then I'll cover the outline slide next.
Sure thing. So first, I'm really excited to have so many people that are tuning in to listen to us. Our main objective is we want you guys to have a reasonable approach to making a good diagnosis for eye problems, to identify who you're able to manage yourselves versus maybe referring to the emergency department or an ophthalmologist, and what our management would be. Antibiotics, yes or no, always hotly debated, and I think Simon will do a great job chatting about that. And then, of course, talking about who needs urgent management. Let's look at some red flags and covering the Edinburgh red eye algorithm.
So how are we going to do that? We're going to talk about the red flags for red eye first. So if you've got somewhere else to be, or you've got lunch, or, well, I guess no one's got anywhere else to be during COVID right now. We'll talk about that first. We'll then talk about foreign body sensation. We'll talk about the itises, and I'm referring to, keratitis, scleritis, conjunctivitis, and episcleritis. And we'll end with a black screen on sudden vision loss. So why don't we dive right in to the red eye red flags. Again, if you don't remember anything else, I'm really hoping that you focus on these three. That was an unintentional pun, despite the many, many intentional puns I'll be making. So this is a chart. So type into the chat if you know the name of the person who invented this chart. And I'm just checking to see if the chat is working. We've got folks from Ottawa, Woodbridge, Aurora, and this is a Snellen chart. So quick tip right off the bat for Snellen charts. Number one is if your patient has trouble seeing the chart and that's new, that's a red flag. And I get quite concerned if the acuity is less than 20/40. That's when I'm going to be calling my ophthalmology colleagues. A second quick tip about Snellen charts: figure out where the tape is on the floor in your clinic. And this actually happened to me when I was locuming in a town in Ontario that I'm not going to name. What happened was I measured the distance between the Snellen chart and the line on the floor. And I did step by step, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And it was a 20-foot Snellen chart, which I didn't know other than from the fact that I Googled the model number on the bottom of the Snellen chart. So I absolutely encourage you to make sure that the tape on your floor is at the right distance from the chart. There's probably a lot of people driving in that small town in Ontario that shouldn't be. So that's one of the red flags, is decreased acuity. I'm so excited, I'm getting ahead of myself. The next red flag, we'll go to the top of the list, is pain. If the eye hurts, then that's a bad thing. Now, the reason this is a specific consideration is because, folks who have conjunctivitis, or folks who've got allergic conjunctivitis, they're going to say, "Oh, my eye is so painful, it's so sore." But when you really hammer it out, when you really nail them down, and you ask them, is it pain or is it discomfort? They're going to probably land on the side of discomfort, because true pain, when you're thinking of acute angle closure glaucoma or you're thinking of scleritis, those are extreme, severe pain. They wake you up at night. They're quite severe. Now, there's some minor conditions that can also cause pain, but I would rather we all err on the side of it hurts, so I'm nervous. And the third one I wanted to mention, the third red flag, is actually got quite a high likelihood ratio of, as Dr. Mike Curley would say, badness. If the pupils are different sizes, if you look at the one red eye and the pupil is a different size than the other one, then you know that is not a good situation. 6.5 is the likelihood ratio there. So these are really the 3 red flags. If it hurts, if you can't see, and if the pupils are different sizes. Dr. Richardson, anything you want to add for things that come right off the bat, red flags that would scare you if you saw them across the room in a red eye?
So decreased acuity is one of the biggest ones for me. Pain, yes, but and as Simon said, you absolutely have to tease out, is it irritated? Is it firm body sensation? Is it aching? Like, what is the degree of pain? Acuity, I actually cheat because honestly, the Snellen chart in my department is nowhere near the eye room. So what I do is I have an app on my phone called Eye Chart. Yes, it is a real thing. You hold it about arm's length or 40 centimeters from the patient, and that can give you a great idea of their visual acuity.
Fantastic. So let's talk a little bit about foreign body. And you never want to make this mistake that this patient almost made, where they had their eye drops bottle immediately next to the permanent glue bottle in their toolbox. So I recommend don't store these next to each other. Dr. Richardson, why don't you tell us about foreign bodies?
Sure thing. So we'll flip, actually, I think even to the next slide, which shows pretty much the same thing. So in the emergency department, and I think also in family medicine or primary care, we see a lot of patients coming in with a foreign body sensation. So the question is there actually a foreign body in the eye? So is it an abrasion or is there a foreign body? I would say most of the time it's just an abrasion, and we're going to manage it as an abrasion. And I think, Simon, you're going to be chatting about abrasions? Absolutely. So we'll stick to the foreign bodies. Far most common thing I see is metal. So people have been grinding, hammering, chiseling, working under the car. My first question to them, were you wearing safety glasses? I really need to know, is this a high-speed impact versus a low-speed impact? So high-speed impact, I'm worried about those. I'm thinking, has it penetrated into the eye? So I have the advantage. I can look with a slit lamp. I'm going to put some fluorescein stain. I'm going to see if there's any aqueous humor flowing out of that. We call that a Seidel sign. And or I'm going to get an x-ray of the orbits to see if there's a little metal body sitting back there. Now, in terms of removal of the foreign body, if it's just sitting really very superficial, regardless of what it is, you can take a cotton bud. Yes, we have vested interest in that, right, Simon? So we're going to take a cotton bud, moisten it a little bit, and see if you can quickly flick it off. If that doesn't work, then we need to become a little bit more aggressive. So usually behind the slit lamp, I'll take a needle, which I actually attach to a cotton bud. I just kind of ram it into the end to make myself built-in handle. And I'm going to use that to pick away at the foreign body, either see if I can flick it out or not. If there's a bit of a rust ring, I'll remove it there. Or finally, I'll use a burr tool. A lot of people have discomfort with burr tools. They're worried that they're going to penetrate through the cornea. Let me assure you, you will not penetrate through the cornea. Descemet's membrane, which is one of the more posterior layers of the cornea, it is strong, and you are very, very unlikely to ever go through. Now, the foreign bodies, I'm not going to touch. Visual axis, so really anything in front of the pupil, anything that's deep into the stroma, because the deeper I have to dig, the more scarring is going to occur. The other area I'm going to look for foreign bodies is actually underneath the eyelid. So under the upper eyelid, patient's going to complain it scratches every time they blink. Just go ahead, flip that eyelid, have a look. Even if you don't see something, take that same cotton bud, give a little swipe across the tarsal conjunctiva, and you'll probably remove whatever was there. So any comments that you would have on that, Simon?
No, that sounds fantastic. So should we talk a little bit about these bumpies?
Oh, yes, we love the bumps. So Styes, and chalazia. So which is which? I threw a little anatomy photo on the left there. So there are actually 3 oil glands in the eye. And the 2 superficial ones, the ones that come out right by the eyelash margin, I would say they're far more commonly involved with the acute infection, which we call an external stye or an external hordeolum. The meibomian gland is a little bit deeper, can also have an acute infection, which we call an internal hordeolum, also a stye. And then finally, the thing that we do see that tends to grumble along for patients a lot is something called a chalazia. So rather than an acute infection, chalazia is just an inflammation. So it's a cyst. And sometimes it flares up and sometimes it settles down. Management approach, very much the same for all 3 problems. Hot compresses, simple, old school. If somebody says they want to use a tea bag on their eye, I'm fine with that. But usually I tell them to take a face cloth, run it under the hot tap as hot as they can stand it, and hold it over the eye 3, 4, 5 times a day, as often as they can do it. Also, a little bit of massage is going to help release those little plugged oil glands. Finally, I get a lot of people ask, do I use antibiotics? Yay or nay? I would say there's no evidence for antibiotics. However, if you do choose to go that route, erythromycin, not bad. Bacitracin ointment, not bad. If it's not resolving within 1 to 2 weeks, absolutely it needs ophthalmologic referral. And chalazia also need ophthalmologic referral because ultimately they will need an I&D done. So they'll just flip the eyelid and curette out the little granular tissues. So that's the quick chat on the bumps.
Christine, I found that there's a huge practice variation. I've worked in rural Northwest Territories where they say just let these fester for weeks and weeks. In Vancouver, they say we want to see them around 8 weeks is what the ophthalmologists have told me. And on Up to Date, they say around 6 weeks. So I found there's a really huge geographic variation in terms of who wants to see these and at what time.
Yeah, I agree.
So I'd like to introduce to you a tool called the Edinburgh algorithm. Now, I guess I should probably disclose that I come from a Scottish lineage, so maybe there's some sort of conflict there. Now, this was fantastic because I found it and it really helped me crystallize how do we approach these red eyes. So I'm actually going to use this as a foundation for the next few conditions we're going to discuss, the itises. Now, the nice thing about this one is it really breaks it down really straightforward. Is it one eye or both? Are the lashes touching or not? And at the bottom, you trickle down and you get to some diagnoses we shouldn't miss. The sensitivity of this isn't perfect. It's about 70%. So that's why I still recommend using the red flags first. But when you get to the bottom, it's quite clear as to the types of different diagnoses. And I'm going to go back to this in greater detail. You're going to ask me, where do I find this? You can find this on the Google if you type in the Edinburgh eye algorithm. The best part too is if you get to the very bottom and you've got any questions, don't call me. You can call this eye clinic in the UK and they actually got their phone number on there. Or you can phone Christine and I'm sure that they would all be happy to help you with your itises. So I want to talk a little bit about some of the itises. We're going to talk about scleritis. We're going to talk about episcleritis. We're going to talk about keratitis and conjunctivitis. Now, the anatomy we need to know here, look, I'm not a bright person like Dr. Richardson. I could not tell you the 5 layers of the cornea. I had to look it up last night. Apparently it's debatable that maybe there's a 6th layer. Like that's way beyond my level. I couldn't even label most of the stuff. So let's just focus on this red blinking box here. This is my area of expertise. And there's 3 things in here that we need to know. So this will set up the framework for the rest of the discussion and it makes it really crystal clear. And that's why it's so important. Number 1, the conjunctiva. Here, let me get my human eye anatomy 2-scale model that I got from the anatomy lab. So this is an actual human eye. So the conjunctiva, if you imagine, it is a layer of clear plastic wrap that really covers most of the eye. And so the conjunctiva is that transparent layer. It covers everything. Now below that, on the next slide, I'll show you, is the episclera. And here's the key anatomic part about that, because the episclera is segmented. There are segments to the episclera, and sneak preview, that's actually going to affect how that pathology presents in terms of a segmented erythema. And the third layer, the deepest layer, this is the deep layer, this is the sclera. It gives the eye its structure. It's the thick white layer. It gives the eye its white color and its structure. And just, it makes perfect sense. If the sclera is compromised, if it's swollen, if it's misshapen, then the whole eye is going to be misshapen and distorted. And you can imagine what that's going to do to refractive capability and the ability of the patient to see. So let's dive into the Edinburgh algorithm to help us understand these. And we're going to trickle down and try and find our way down to this one here, episcleritis. Now, for those of you who aren't diagnosing episcleritis, it's probably because you're like me when I just came out of residency and I had no idea that it even existed. We probably see this way more often than we realize. And I guarantee you that if you haven't done the background reading like I hadn't done when I just started my practice, I was probably calling these a lot of viral conjunctivitis or allergic conjunctivitis. So what's the difference? So notice right away, this is different than pink eye. You can see there's a white part of the eye and there's a erythematous part. Remember I said that the episcleral layer is segmented and it makes perfect sense. It's like a pizza slice in here. Part of it's affected and part of it isn't. Now, a couple other pictures. It's not that whole diffuse erythema. It's usually painless and it's usually segmented. And the treatment of these are going to be lubricants and NSAIDs. Now, most of these folks, I see them 3 times. They come in to see me once because they think they've got pink eye, or they'll come in a second time because they saw someone else who said, you don't need antibiotics, and they're begging for antibiotics at about the 6 or 8 day mark. And then they come in at the 3rd time about 2 weeks if they weren't advised that this takes a couple of weeks to go away on its own. Now, one of the times that I gave this talk, I had a family doc come to me, and he said, look, Simon, he put his hand on my shoulder. I'll never forget it. He said, why are you so anti-steroids? Because, you know, a little bit of steroids on an episcleritis makes it go away so easily. And I'll tell you why. And for the residents watching who have SAMPs coming up, if there was a SAMP question that said list 4 complications of giving steroids to somebody's eyes, they're all bad. You don't want any of these. So number 1, you could worsen herpes simplex, conjunctivitis, or keratitis, as many people know. Number 2, long-term, they can cause cataracts. Number 3, they can end up with glaucoma. And if you even give a 2-week course of steroids, 2 weeks, that's all it takes to end up giving somebody acute angle closure glaucoma. And the 4th one, I'm not an ophthalmologist or an optometrist, but this is a really bad thing when it comes to the eye. Eye steroids can cause a condition that you don't want, known as globe rupture. So that's what eye steroids can do to your eye. Please do not prescribe eye steroids if you're in primary care. We don't want that to happen. And that didn't dry out as much from last night as I was hoping that it would. So there's bits of egg falling onto my trackpad, zooming into the screen here, and bits of yolk. So I was not expecting that complication. So before we go into from episcleritis to scleritis, Dr. Richardson, is there anything you want to add when it comes to picking up the diagnosis of episcleritis?
So with episcleritis, I've often found patients have a little bit of discomfort. So not pain. Scleritis is painful, but certainly some discomfort. I agree with you absolutely in terms of not using steroids. I have seen people with their corneas sloughed off because of uncontrolled herpes keratitis, because somebody decided to put them on some sort of steroid drop. So
CMPA's got some great stories on family docs who thought it was a good idea to use steroids. So why don't we just leave it at that? If you want to hear the stories, ask me sometime. The next layer of eye conditions is called scleritis. So this is one that usually would present to emergency or urgent care because it is severe. It is extreme pain. It is that foundational thick white layer of the eye that gives the eye its structure. And that is the one that is inflamed when it comes to scleritis. So these people have severe pain. They describe it like a boring pain, like a rod being jammed into their eye. They've got a diffuse purpura or erythema, and you'll see on some of these photos that there's a diffuse purpura, and these are the ones you want to refer urgently. They're going to need, they usually do get steroids, but again, they're getting steroids from an ophthalmologist who can monitor the eye pressure ongoing. Now, I'm recognize that many of you work rurally like I did back in the day when I was doing several locums. And so I wanted to have a great tip for rural. Just like Dr. Richardson said, if you are working rurally and you see a patient with episcleritis, you may say, well, they've got pain. Is this something that needs to be medevaced for $40,000, or can they stay here and we can observe them? So obviously I'm going to have the ophthalmologist on the phone, but one of the things we can recommend is the cotton tip test. So we can't use brand names, so we're just going to talk about cotton tips. This is a video that I'll play a few times over and over with no sound. This is a patient that I saw with episcleritis. Now remember, it all comes back to that anatomy. And so when I move the outer layer of this anesthetized eye, you can see that the vessels are moving. And remember, the superficial layer is the episclera. If this was scleritis, you're not going to see those deep layers moving around. All you can move with a cotton tip is the episcleral layer. So if the layers are moving, you know it's episcleritis. If the inflamed red layers are moving, you know it's episcleritis. If they're not moving, if they're fixed, if they're firm, they're in that deep layer of scleritis. And that's going to make you worried that this painful red eye is scleritis and they need to be seen by an ophthalmologist. So anything to add for scleritis, Dr. Richardson?
Sure. Are you going to chat about some dilute phenyl just as a way of differentiating between the layers?
Absolutely, yeah. Please go ahead and talk about phenylephrine drops as a way to distinguish them. That's a fantastic tip.
Yeah, so, and again, this is more for people who are going to be working in a more remote community. A nice way of telling the difference, if you use some phenylephrine drops, so essentially a very dilute phenylephrine, it is a vasoconstrictor, but it won't penetrate into the sclera. So it will constrict your conjunctival vessels. It'll constrict some of your episcleral vessels. It will not constrict your scleral vessels. So again, if you pop it in and you still have that deep violaceous hue, you're likely dealing with a scleritis.
And it all comes back to that anatomy sandwich, right? Conjunctiva on the top, episclera in the middle, and sclera deepest layer. The phenylephrine cannot trickle down to that deep scleral layer. So again, it's got to be really simple for me to remember it. So speaking of simple things, let's talk about the disease named after Bugs Bunny's favorite food. This is keratitis. Now, there's a couple different kinds of keratitis. I couldn't tell the difference. To be honest, it doesn't really make a difference from my end. And Dr. Richardson maybe can disagree with me very shortly. But this is the most beautiful kind of keratitis. This is the kind I get excited about. And I asked to pull up the camera because it's so lovely. This is called a herpes simplex keratitis. And they've got that beautiful branching dendritic pattern of the neurons, the kind of shape that you can see on the outer layer of the eye. Now, Dr. Richardson also mentioned earlier that we should talk briefly about abrasions. And sometimes if you get a traumatic injury to the eye, you can get a stellate injury, a stellate damage, a stellate abrasion to the cornea that might look similar to this. So, of course, the pictures in real life aren't as beautiful and branching as the ones on the internet. So that's why it's so important to find out, is there the history of an abrasion? And so I'll talk about abrasions now. One of the key points for abrasions is you want to make sure that antibiotics are up to date. I've also seen folks who, antibiotics are prescribed for this patient, a lubricant eye drop. The research on abrasion says we should not be putting, firm pads of gauze and taping them down hard on the eye, because that can actually just worsen the abrasion. So there's a lot of different randomized controlled trials that have demonstrated that. And some folks would actually update the tetanus for a corneal abrasion from a traumatic body. It might be overkill, but hey, if they're in your department, then I think that would be not unreasonable. So before I move on to keratitis, Dr. Richardson, is there anything you want to add about corneal abrasions?
So with corneal abrasions, I typically do not use antibiotics unless the abrasion is caused by an organic source. So tree branches, not good. Fingernails, not good. Those are the ones that I typically will give some sort of antibiotic prophylaxis for. Never more than 5 days. Tobramycin, definitely not my favorite choice. Again, you tend to get a bit of toxicity with the aminoglycoside class of antibiotics. So something as simple as polysporin drops are probably fine. It's polymicrobial. Ophthalmology gives Vigamox or moxifloxacin eye drops to everybody. So I think you can't really go wrong if you give antibiotics, but please be judicious in the use of them and don't use them for every single corneal abrasion.
That's useful to know. Again, the evidence on this is quite thin in some regards. We'll talk a bit more about that when it comes to the conjunctivitis. So let's wrap up our notes on keratitis. So again, if they don't have the traumatic history, you do the fluorescein eye drop and you see this pattern, you're thinking herpes. Now, there's other kinds of keratitis. I wish someone had told me this in med school. You mentioned our training in med school was so limited. I think that my ophthalmology training in med school could be summarized in 3 words, which was refer, refer, and refer. That was pretty much all I learned in med school. So one of the things that I wish I would have heard is that keratitis can also be punctate. You can get punctate epithelial erosions, just little pinpoint drops with inflammation. And so I had a patient come into my clinic in Northwest Territories. We misdiagnosed them as having an iritis. It looked just like an iritis. I'm going to talk about iritis. Not today, we're not talking about iritis, but iritis, you get that photophobia, you get that pain with the pupil constricting. And I thought it was an iritis, but we hadn't done a fluorescein. And so I'm begging you, don't make the same mistake that I did. Do the fluorescein eye drops first before you call optometry. So fortunately, there was about a 20-minute delay in that diagnosis. We called optometry in Yellowknife and they said, what did the fluorescein show? And we said, hold on a second. So the keratitis wrap up here, there's a few different causes. Again, antivirals for the herpes keratitis. There can be fungal keratitis. There can be traumatic keratitis. And we want to refer these folks urgently, especially if there's a herpes outbreak there. They need to be monitored. They need to be made sure that they don't have prolonged compromise of their eye. And please, for the love of everything that is beautiful, do not give these folks eye steroids. Otherwise, you could end up with a permanent ocular compromise. So that's it for keratitis. Before I begin talking about conjunctivitis, Dr. Richardson, anything do you want to add about keratitis?
Sure. So I see quite a bit of viral keratitis. So again, it's those that punctate epithelial erosions, often with a little bit of infiltrate. So you may see some little teeny tiny dots of white or white blood cells that are throughout the cornea. That would be diagnostic for it. These tend to be managed very conservatively. So just some artificial tears or any kind of ocular lubricant is great. I apologize, by the way, for the dog in the background. That's the disadvantage of doing teaching from home is Spencer. But again, back with the viral keratitis, I just tell them it's going to settle down on its own. If you can follow them up yourself, great. If you have a local optometrist, fantastic. Lubricant eye drops, absolutely no contact lens wear until it is 100% resolved. And that can take 6 weeks or more. So people are really surprised when I say this is going to last for a while. It does.
Fantastic. And I've got a newborn downstairs. So if you hear any crying, it's probably either mom or me who haven't slept very much lately. So much appreciated to those of you from Main Spadina Health Center and Joseph Gabriel who are putting questions in the chat. So we do see those coming in, and we're going to have a moderated Q&A session at the end. So we'll definitely get to your questions. If anything comes up that sounds a bit fishy or confusing, or you've got a question, please do put them in, and we'd love to address those. So let's get to a part of the Edinburgh algorithm that we see most often, and we're talking about conjunctivitis. Now, they've got allergic conjunctivitis and they've got infective conjunctivitis. And I can just envision the folks making this algorithm trying to say, should we be distinguishing viral or bacterial or viral or bacterial? Bottom line, the evidence right now says it probably doesn't matter. We know that 65% of bacterial conjunctivitis gets better without antibiotics. So we'll talk about that very shortly. That's at the 3-day mark. There was a meta-analysis from the Outstanding Tools for Practice from Alberta, and they had a collection of about 3,500 patients with viral conjunctivitis, and there was 0 bad outcomes. Folks didn't get blindness because their family doctor forgot to give them eye antibiotics. So we shouldn't be stressing about that if the patient has no red flags and we've counseled them appropriately. I mean, it can happen, but it's exceedingly rare. So what do we need to know about conjunctivitis? Now, let's focus first on infective conjunctivitis. Notice this is different than the episcleritis. Remember, the episcleritis is segmented. There's parts of the eye that have erythema and parts that don't, whereas conjunctivitis, remember the anatomy, it's that clear layer that surrounds all of the eye. And so when all of the conjunctiva is inflamed, you're going to get erythema on all of the eye. So going back to the slide, you can see the diffuse erythema. This is an allergic conjunctivitis picture. You can see once they flip down the lower lid, you can actually almost imagine there a bit of a cobblestoning from the edema in that conjunctival layer. So that's a suggestion that there's inflammation there. Again, another picture of diffuse erythema. We want to be making sure there's no red flags. It's not painful. We want to make sure that they don't wear contact lenses. We want to make sure that the pupils are the same size on both eyes. And the discharge thing, I mean, probably the best way to distinguish viral from bacterial is to have a bedside adenovirus test. So I see one of our viewers is from Colorado. Maybe you can type in the chat and let us know if you've got a bedside adenovirus test for your pink eyes. I know they use it in the United States. We don't have it routinely in Canada. So a lot of this is going to be clinical. You're going to be looking at an eye like this and saying there's a lot of pus there, so probably it's bacterial. And that's pretty much the best we can do. The folks who have viral conjunctivitis, they're going to say, oh, I need antibiotics because my eye is crusted. But when you ask them, you'll find out their eye is crusted in the morning, and then by the time they see you and throughout the day, there's no crusting, there's no discharge, there's no pus. And so I tell them, that's just dried tears. And for some reason, when I say that's just dried tears, they seem to be quite alleviated, and they don't want the antibiotics as much, which is a good thing, because even back about 10 years ago, Cochrane did a review on antibiotics for acute bacterial conjunctivitis, and it was a coin toss, really. They said use of antibiotic eye drops is associated with modestly improved rates of clinical and microbiological remission in comparison to the use of placebo. And then the conclusion from that could really go either way. So they chose to say you should consider antibiotics. And they could have just said, so antibiotics are not recommended. I mean, it seems like it's a wishy-washy, because that's really where the evidence is right now. So what's a more recent meta-analysis, again, from Tools for Practice, and they said that compared to placebo, topical antibiotics will lead to resolution of symptoms with a number needed to treat of about 12. And this is the meta-analysis that said if you don't treat, you're still not going to expect bad outcomes. So what do I give these patients? Because often I feel like I want to give them something, and they want to feel like they got something. So we talk about conservative management. I print them a Choosing Wisely brochure. I talk about cool, clean, wet compresses, artificial tears over the counter. Allergic pink eye can be alleviated by antihistamine eye drops. But for bacterial conjunctivitis, with one major exception. We don't need to use antibiotics. So I'll talk about Pseudomonas and contact lenses on the next slide. But before I do, Dr. Richardson, go ahead.
So agreed. We see a lot of allergic conjunctivitis, a lot of viral conjunctivitis, very little bacterial conjunctivitis. Most of the time, it's not going to be bacterial. So I rarely am giving out antibiotics for this. I think a lot of people will want to know, well, what about kids in daycare? They're not allowed back in daycare unless they're on antibiotics. Again, like Simon, I try to give them the information about the Choosing Wisely campaign, and hopefully they understand, but it can be a real discussion with people. Couple of additional conjunctivitis that we will see. So unfortunately, we do see some chlamydial conjunctivitis. That tends to have quite a good purulent discharge similar to bacterial, but they also have very significant preauricular lymph nodes. So if you just kind of feel in front of the ears, and you're going to feel those tender and large lymph nodes on the one side, and that's a little bit more pathognomonic for chlamydial conjunctivitis, which would likely treat with oral antibiotics.
Absolutely. The incidence of chlamydial conjunctivitis is going up at the 18 to 25-year-old age range. It's up there. It's 20% or so. So thinking about swabbing folks in that demographic who are sexually active, you're gonna get some positive results if you do that. So now, no pink eye talk would be complete without giving you the right act about pseudomonal eye infection. So I want to tell a story about this patient who is a patient of mine who kindly agreed to have her photograph taken for this talk. This is a lady, she was wearing contact lenses, and she went to the emergency department because she developed a pink eye. And I asked her this story. She was seeing me for an unrelated issue, and I said, hold on, you went to emergency department? That seems like overkill. But I said, what was wrong? Like, did you have any red flags? Did you have any trouble seeing? And she said, I could see fine. I said, well, did you have any pain in your eye? She said, it wasn't hurting at the time. I said, did you have any change in the shape of your pupils? And she said, are you crazy? I wouldn't try and measure my pupils before I go to the hospital. But the fact is, she had none of the red flags, and she went to the emergency department, and they swabbed her eye and then gave her antibiotic eye drops, which again kind of goes in the face of what we said earlier, because we're not really supposed to swab eyes unless they're neonates or unless we think that there's chlamydia. So maybe the emerge doc did a bit of overkill, but then they gave her antibiotics, which again, we did just say bacterial conjunctivitis doesn't usually need antibiotics. But the reason she got the antibiotics is because she wore contact lenses. So the very astute physician said, you wear contact lenses, we need to be terrified about the risk of Pseudomonas eye infection. And they fortunately gave her the antibiotic. They gave her moxifloxacin, but the swab came back positive for Pseudomonas. And by that time, it was too late. When I ask my local ophthalmologist about Pseudomonas eye infections, I see the blood drain out of their face. And they use terms like corneal melting. And they tell me about like compromise to the eye within hours. And so this lady, she got the best possible treatment immediately. And she's, if there's any ophthalmologists watching, I've had an ophthalmologist look at this very picture, and she was able to distinguish, oh yeah, these are the different surgeries she had. She clearly had a graft, it didn't take, so they had to revise it. So this patient does not have good vision in this eye whatsoever. So this is why Pseudomonas is that must know, can't miss diagnosis. If there's any suspicion that they wear contact lenses, I always err on the side of giving antibiotics. So we're about 9:35 in BC time, 12:35 for all the Ontario folks who just panicked when I said that. So we've got a bit of time before we get to our next section. So yeah, there's some time for Dr. Richardson to comment here, and then we'll have lots of time for your questions at the end.
So Simon made the good comment about if you wear contact lenses, err on the side of caution, give antibiotic eye drops. I typically will. Same thing for corneal abrasions. I'll provide antibiotic drops with contact lens wearers because it is a risk factor, particularly for Pseudomonas.
And yeah, that Pseudomonas should make the hair stand up on the back of your neck. Absolutely. So the last point I wanted to make was about the bottom right on the Edinburgh algorithm. So you've got a patient with bilateral eye erythema. It's gritty and burning. It's not painful, and there's no discharge. Well, if everything else is normal, you can diagnose those folks with dry eyes. They've got a diffuse erythema. It's not segmented like Episcleritis. They don't have red flags. It could be dry eyes, and it could improve with just a bit of lubricant eye drop. Now, interestingly, notice there's a different one on the other end of the Edinburgh eye algorithm that's very similar. And they say this is a one eye red eye. Maybe there's a cranial nerve, 7 palsy. So what are we getting at here? And I got a great photo from Wikimedia Commons, which is being used with attribution in the speaker notes. So this is a patient who has Bell's palsy. And you'll notice when they try and shut their eyes, they cannot completely close the left eye. So this is a patient who might end up being given a diagnosis of unilateral dry eyes if they had that diagnosis missed, or if the clinician wasn't astute and said, oh, you've got Bell's palsy. We need to think about protection of your eye. Now, the interesting thing is this patient has got severe enough Bell's palsy that they really have to mash their eyes closed. If a patient has got minor Bell's palsy, this can be a pitfall in that you say, can you please close your eyes? And they close very tightly, and they may actually be successful at closing their eyes. So the real tip here is you've got to watch them while they're speaking to you. You've got to watch them while you're talking before you tell them to shut your eyes hard, because what can happen is during that time, you might notice that one of the eyes is closing completely and the other lid is not closing completely. And if it's a minor Bell's palsy, you say, please close your eyes tightly, and they will be able to close them completely. So make sure you're being observant, chatting with them in the history and watching their eyes while they do that. So that's it for dry eyes. We treat these with lubricant eye drops. The next slide is photopsia, Dr. Richardson. Anything you wanted to add about either of these two conditions on the screen right now?
Sure. I'm just going to chat quickly. Somebody, actually one of my colleagues, asked the question on the chat about the differentiating between keratitis and dry eye staining. So typically keratitis is more diffuse across the entire cornea. If it's caused by dry eye or lagophthalmos, meaning the eyes don't fully close, particularly at nighttime, it's typically going to be staining only along the inferior part of the conjunctiva. So that's one of the best ways to differentiate between the two. I'll also, if I'm considering dry eye as a diagnosis, I'll put some fluorescein stain in, not copious amounts, just a little bit. And then I actually watch to see how long it takes for that tear film or the fluorescent pattern to start breaking up. If it's less than 5 seconds, it's definitely going to be dry eye, and you're going to treat it with some ocular lubricants. And often at nighttime, you're going to want to use something that's a little bit thicker, any kind of gel, or even an ointment if it's bad enough. Bell's palsy, quick tip, because I did have it once. Instead of taping the eye shut at night with Lacrolube, throw in some Lacrolube. Yes, I know I'm using a brand name, but any kind of ointment, and then just put a nice little eye shield or sleep shield over the eyes. That's going to hold it comfortably closed overnight. Much better than tape.
That's great. So I'll turn the reins over to you, Dr. Richardson. We'll talk about photopsia, sudden vision loss, and then we'll round out the hour with your questions. So go ahead. Perfect.
So photopsia just means essentially a visual disturbance. So we're going to talk really only about a couple because I want to differentiate between flashes and then flashes and floaters together. So if we can flip on to the next slide there, or even that one after that. So the first one I'm going to talk about is, are the flashes coming from either the eye, which we'll talk about in the next slide, versus a brain effect? So migraine auras, very uncommon, even in people who have migraines. Only about 10% of migraineurs will have visual auras. But these will typically last, anywhere from 10 to 30 minutes. It starts as a little bit of a shimmering, not typically very colorful, may progress to a scotoma, and it will increase in size over that time frame, and then it disappears. Most people will get a headache afterwards, not everybody. When they get the headaches, it's really quite severe, typically unilateral, pulsating. They have a lot of photophobia and nausea with it, maybe some vomiting. Another phenomenon, though, that I think is often missed is an occipital seizure. So please don't ever make the diagnosis of migraine or visual aura in an older patient. Think, what else can it be? Is there something else going on? So an occipital seizure is a little bit different. So the time frame is different. Migraines 10 to 30 minutes. It builds up over time. With the occipital seizures, it's going to be typically under a minute, at most 3 minutes. And it's round circles, big bright lights. Sometimes it's on the right, sometimes it's on the left, and often it'll cross right across the midline. They may get a mild headache afterwards as part of their post-ictal state. So again, I think this is something to not be missed because it's very manageable with the appropriate anti-seizure medication. Carbamazepine is key. I would not be making this final diagnosis in a patient, but I'd want to think about it and then refer to neurology or neuro-ophthalmology for better diagnosis, plus or minus some imaging that can be done. Again, it doesn't have to be done emergently, but we do need to consider it. So again, I just think it's something to think about. Next one is flashes and floaters. So we see this a lot. People complain, they come in, oh, there's a cobweb in my eye, or I'm seeing these little dots and dashes. Very noticeable when I'm looking at a plane surface, such as the sky or against a wall. Again, most of the time, this is vitreous syneresis, very normal aging, as we like to say, change in the eye. So the vitreous starts to coalesce. You get your hyaluronic acid, so the little proteins in it start to coalesce. You get little chunks of that, and then gradually it starts to pull away from the retina. When it's pulling away from the retina, what we're seeing are little bits of the little coalesced parts, and also something called a Weiss's ring, which is where it's round, connected right around the optic nerve head, and that starts to pull away, and you see this round or irregularly shaped round object sitting in front of your vision. As it's detaching, it may put some traction on the eye. So when it's pulling against the retina, people are going to have photopsia or flashes. I want to know from the patient, where in your visual field are those flashes? And I'm going to have a very good look at their retina to see if there's anything going on there. Most of the time they get the flashes and then it just pulls away without a hitch. They get a few more floaters and they're good to go. My management for these patients, none of them need emergent assessment, but they all deserve a dilated examination by either their optometrist or their ophthalmologist. And what they're going to be looking for is a small hole or tear in the retina, which we're not going to be able to see. Let's face it, we use a direct ophthalmoscope. We can see the disc, maybe the macula, and not much more. So they need a dilated exam. They're going to have a really good look around and see if there's a small hole that's formed. If there's a small hole, that will potentiate towards a retinal detachment, which I'll talk about in the vision loss section. And they can essentially spot weld it. They just do a little blast of laser, close up the hole, and they're good to go. But we do see a lot of these. Again, I think most people, by the time they're in their mid-60s, this has occurred. Typically one eye more than the other. People who are very, very myopic, they will have lots of floaters at baseline. One of the key features I do want to ask my patients, so I'm going to ask about vision loss, and I'll do a visual field exam with them. And I want to know the nature of the floaters. So is it just the little dashes and dots or little squiggles or cobwebs, or did it look like a swarm of flies? If they tell me they see a swarm of black dots that are really starting to obscure the vision, I'm concerned that they're seeing erythrocytes or red blood cells sitting in front of the retina, and that's more of a harbinger of retinal detachment or hole. Any comments on that, Simon?
Nothing to add, and why don't I'll keep my comments short so we got time for questions and answers. Okay.
So sudden vision loss. So what defines sudden vision loss? Is it like one moment you can see and the next you can't? Nah, it'd be nice if it was that easy. It can be very gradual. So when we talk about sudden vision loss, we talk about the time frame anywhere from seconds over a period of a few days. Now, there will be 3 general causes of your sudden vision loss. So is there something in the media that's obscuring your vision? So is there something that's stopping the light from getting to the retina? Are there actual problems with the retina or the eye itself? Or is there a neuro-ophthalmologic problem? So is there a problem with the optic nerve anywhere from the orbit all the way back to the occipital lobe? So is it one eye? Is it both eyes? Is it blurriness? Is it black? These are the descriptors that I want to try to get from my patients. I mean, the differential is huge, and I love to grill my residents on it all the time. If they can come up with 5 or 6, I think they're doing pretty well. All right. So let's head on to, so that's the why, the what, the why, the where. So central scotoma, so losing the middle of the vision, something off to the side, or is it a complete blackout? All right. So let's talk about a retinal detachment, because these are things that we don't want to miss. Again, it's a unilateral vision loss, and most of the things I'm going to talk about today will be unilateral. So unilateral vision loss often, but not always, preceded with flashes of light. What the patients will describe is, I can't see. Well, what can't you see? Is it a curtain? Is it darkening? Which part of your vision is it in? The retinal detachments really, once it's there, it's there. We're not going to manage these, but how quickly do we need to get the ophthalmologist to go and have a look at it? If the macula is on, so they have very good visual acuity, but they have lost the inferior part of their vision, meaning it's a superior retinal detachment, they need to be seen by ophthalmology today, not tomorrow, today. Give them a call. This is a macula on. We do not want this to become a macula off retinal detachment, because their vision will never be the same. Once the macula is off, they will always have distorted vision in that eye. But if it's an inferior visual detachment or retinal detachment, so a superior visual field loss, they can be seen the next day or a couple of days later. I mean, from my perspective, I still want them seen today, and I'm a little bit spoiled where I practice because we do have residents that'll see patients the same day. But if it's an inferior one, they can be seen the next day, and ophthalmology will take care of that. Now, for those who work in an emergency department, I think it's the next slide. Hopefully it will play. And for those that love using POCUS, or point of care ultrasound, for pretty much anything and everything, this is not something in your family practice, but most small emergency departments as well as academic centers will have an ultrasound. Very easy. There is a quick link on the right if you want to have a very good review of how we can use the POCUS. One of the things you'll see in the center at the bottom of the eyeball is this dark area. That's the optic nerve. If it's a retinal detachment, you're going to see things floating around, but it looks like it's still attached at the optic nerve. If it's a vitreous detachment, the whole thing is forward and there's no attachment at the optic nerve. But again, I would advise you, if you have a chance, go to that video. It's fantastic. It'll tell you detachment, vitreous separation, as well as vitreous hemorrhage. All right, we'll have to keep moving along because I'm trying to be cognizant of the time. So retinal artery occlusions and retinal vein occlusions, or branch vein occlusions. Risk factors is the biggest piece that we need to address. So it is the same as for stroke, particularly with an artery occlusion. So think of your vascular paths, people who have a hypocoagulable state. So their pregnancy, they're on the birth control pill, protein CNS deficiencies, factor V Leiden, polycythemia, lots of causes for this. An arterial occlusion, they lose their vision. They see nothing. It's rapid. If they don't get treatment within 4 to 6 hours, they will lose their vision permanently. And there's nothing we can do about it. Most of the time, they present far too late. If they present early, please call your ophthalmologist, get them sent in. There's a few little tips and tricks that they can do to help this along. Typically, the retina will be very, very pale because it's not getting its vascular supply. We call it a cherry red macula. So the macula looks red, not because it's getting a blood supply, but because you're seeing the blood supply from the choroidal layer underneath it. So the macula is the thinnest part of the retina. So that's why it looks red. A vein occlusion we call blood and thunder. So the veins occluded, blood can't drain out of the eye, and it starts to leak out of the blood vessels. So again, when you look in, you see all these hemorrhagic or dark hemorrhages. You'll often see cotton wool spots as well. And again, same population, so vascular paths. Diabetes is a huge risk factor for these. And the acuity is typically going to be less than 2100 for this. Who do we need to refer? Both of them. CRAO, like I said, within 4 hours is great. If it's delayed, there's nothing ophthalmology can do. CRVO can be dealt with over the next few days. Doesn't have to be same day, but certainly you'd like them seen within a couple of days of having this happen, because there are some treatments that they can do for it. So next slide. Blood in the vitreous or in front of the retina. Patient says, I can't see well, typically very blurred. It's not going to be black, but it will be less than 2400 or even hand motion only vision. When you look in, you see a whole lot of nothing. So you might see a little bit of a reddish haze, but really you're not going to be able to distinguish anything in the anything on the retina. So these ones, again, they all need a referral. Most common cause for this is people with diabetes. So they have a proliferative diabetic retinopathy. That means they get blood vessels that grow, and these blood vessels are weak. and then they tend to rupture and bleed. So ophthalmology and optometry see these patients every year, and if they see any signs of proliferative retinopathy, they are seen by ophthalmology, and they actually get some laser treatments to try to decrease the need for the extra vascular. Any comments on that, Simon?
No, I'll leave you to it. So we got a couple minutes left for questions.
Perfect. So optic neuritis, we do see this sometimes. Patients will complain of anything from a mild visual disturbance and photopsia to complete vision loss. The big pearl on this one is that things look darker. So if I want to make a diagnosis of optic neuritis in a patient who's come in with a little bit of an achy eye and a little bit of a visual disturbance, I look at the eye, maybe I'll see some papilledema, maybe I won't. But I take something with a red cap, so it can be a red pen or an eye drop with a red cap on it, and I just go back and forth between the eyes, and the eyes that's affected, it looks darker. And they'll consistently say that. The other key is to look for an afferent pupillary defect. So you shine the pupil in the affected eye, both pupils dilate, shine it back to the normal eye, both pupils will constrict. So that's just, I won't talk about too much. If you do see it, they all need a referral. They all need imaging. We have to think about MS. We also would want to think about giant cell arteritis. So I would send all of these either to the emergency department for further assessment or to ophthalmology. And the last one, I'm not even really going to talk about this too much because there's so much to talk about in neuro-ophthalmology. I could do a 2-hour or more talk just on this, but we're just going to talk about pre-chiasmal, chiasmal, and post-chiasmal vision loss. So if something is pre-chiasmal, so it's severed the optic nerve or affecting the optic nerve before it reaches the chiasm, it is going to be unilateral vision loss. Something that's affecting the chiasm, so pituitary tumors in particular, that's going to cause compressive lesions or going to affect your outside vision, what we call your temporal field. And then anything post-chiasmal is going to affect both eyes again, but it's going to be opposite to the side of the lesion. Again, I don't want to go into too much of that, but if somebody comes in with visual loss that you think is chiasmal or post-chiasmal, absolutely, they all need a CT of the head urgently. Pre-chiasmal lesions, see if you can figure it out yourself or with the help of your local friendly neighborhood ophthalmologist, and they may or may not need some imaging. So that was a very rapid run through on all of that. I know we've got a few questions, so hopefully we have time to answer the most pressing ones.
Great. Well, thank you to both Dr. Richardson and Dr. Moore for what a great presentation. Lots of pearls, clinical pearls being dropped there. We do have a few minutes and lots of questions. So I'll get right to it. The first question, I'll hand it over to Simon first. So Simon, you definitely woke me up more than I was already engaged with the presentation when you said the eyeball would melt, with Pseudomonas. And then we had a question about antibiotic and contact lens wearers. So I guess the question is, when do we know we should use antibiotics? How do we know that it could be Pseudomonas? Is there some ways, some tips of the trade that you could help us with that?
Yeah. So what does the evidence say about distinguishing Pseudomonas at the bedside? There's not a lot of papers on it. So I always err on the side of give the antibiotics if they wear contact lenses. Give the antibiotics if they wear contact lenses, and you want to be using a fluoroquinolone like moxifloxacin or ciprofloxacin. Dr. Richardson, any thoughts on that?
As you said, the evidence is, so like you, I will err on the side of caution. I'm going to use my antibiotic drops if they wear contact lenses. You're not going to get sued if you treat them with antibiotics, even if there's a bad outcome, as long as you've got good follow-up.
Great, good answers there. And I guess as a follow-up, if we're seeing these patients in clinic, a common question could be, well, doctor, when can I go back and use my contact lens again? So after I have a bout like this, Christine, maybe I'll start with you. When do we think that people can wear the contact lens again? They
can't wear the contact lenses until everything is healed. I will arrange follow-up for them because I don't feel I'm the one who's going to make that decision. It doesn't have to be made today, and it can be anywhere from a few weeks to a few months to never.
And hopefully not the same contact lens going back in there.
Hopefully not. Hopefully they've got another spare of it.
Yeah, that they rinsed under the tap.
That's right. Another question, Simon, you mentioned about episcleritis, about topical NSAIDs. I guess for episcleritis, are we giving topical NSAID drops to patients? There was a question on the chat about that as well.
That's right. You can get ketorolac eye drops, and those are inexpensive. They're available in Canada. I personally would only prescribe those if the lubricant eye drops aren't effective. Dr. Richardson, you want to add anything?
No, I was going to suggest ketorolac and just lubricant.
And speaking about lubricant and also eye drops, there was a question also about patients in the elderly with excessive tearing. Is there a moisturizer or some sort of a lubricating eye drop that you would recommend in those of us who are caring for elderly patients? Simon, maybe I'll start with you, and then Christine to add.
I used to say just go to the drugstore and grab anything that looks like it's an artificial tear, but I have found in Canadian drugstores there are homeopathic products interspersed amongst them. So technically there shouldn't be much adverse reaction from that, but I usually tell them to get a non-medicated lubricant eye drop. Again, happy to throw to Dr. Richardson for your expertise too.
So excessive tearing is often a sign of dry eye, believe it or not. So I'm going to tell those patients to start with some eyelid rubs. So they may have a very mild blepharitis or plugging of the oil glands that are coming out of the eyelids. If that fails, then certainly some eye drops, and usually something a little bit thicker. So any kind of gel is very helpful because it will last longer in the eye. The other thing that you want to look for is in the elderly, you're often going to see some weakening of the eyelid. So essentially it starts to flop out, or an ectropion. And in that case, the puncta, which is in the medial part of the eye, they're not going to meet. And then the normal tears aren't even going to drain out of the eye. So it's more a function of the eye anatomy rather than the tear film. So do have a good look at it. And if there's any signs of ectropion causing this, which I would say is even more common as a cause of excessive tearing in the elderly, then again, that would need to be dealt with ophthalmology. And if it's bad enough, there's surgical procedures to fix that.
Great, perfect. And maybe one last question before we wrap up for the day. There's a question from one of our viewers. She says she's got a patient with rosacea, and this patient gets repeated styes from their rosacea, and this patient always seems to want antibiotics. Is there a different antibiotic than maybe the go-to erythromycin that we could recommend? Maybe I'll start with Simon, and then we'll wrap up with Christine.
To be honest, usually by that point, I've referred them on to a higher level of care. So Dr. Richardson, any thoughts?
Sure. If they're getting recurrent problems, then you may want to treat a little bit more orally or systemically. So an oral minocycline would be your best choice for that.
Perfect. Thank you very much to both of you, certainly for an insightful presentation, lots of clinical pearls. All of these presentations are recorded, and I certainly will be one to watch the recording over and over again to capture all the points that are made. Just to remind everyone, to claim MainPro Plus credits, please fill out the online survey. That will be open until end of day Friday. The address is in the chat room. It's also being displayed here on the screen. Just to remind all of us of our upcoming webinars, the COVID-19 Pivot, Putting Vaccines in Action, and more updates will be on March 23rd, 2021. And also into April, we've got top research studies of 2020 with Dr. Mike Allen in English on April 20th, and then also with Dr. Nick Dugray in French on April 27th. Once again, thank you for joining us. Keep safe and take care.
Take care.